Good morning, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly. Okay, good morning, everyone. Thank you so much for joining us for Virtual Insights on Kidney Transplant. Our topic today is kidney transplant and quality of life, what the data tells us. Our speakers today are Judith Hambleton, Chief Transplant Coordinator, and Eliza Bensley, Clinical Transplant Educator. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered, and it is now my pleasure to turn things over to Eliza.
Good morning, everyone. Thank you so much for joining us with our new series, Virtual Insights on Kidney Transplantation. Today, we are talking about kidney transplants and quality of life and really focusing on what the data tells us. So our very first topic that we just really want to cover is, what does quality of life really mean? So it's a broad concept covering all aspects of human life, whereas health-related quality of life, HRQOL, which we'll see later in the slides, focuses on the effects of illness and impact that treatment has on your quality of life. So, as you can imagine, quality of life and health-related quality of life is highly subjective. It represents a broad concept of physical, psychological, and social functioning and well-being that includes both positive and negative aspects. So for people with chronic medical conditions, this includes how their disease and treatments impact their everyday function, and the impact of social determinants of health, which is a term we'll discuss in the next slide, plays an essential role in a person's quality of life. And overall, if you've ever been asked to fill a patient-centered survey, they're commonly used to assess and monitor health-related quality of life outcomes to better improve the system worldwide. So I mentioned social determinants of health. The next slide, we will kind of cover what that means. This is kind of like a public health review for the start of this. Social determinants of health are the non-medical factors that influence health outcomes. So those are conditions in which people are born, grow, work, live, age, and there's a wider set of forces and systems shaping the conditions of daily life. I like this image because it's very clear-cut that our healthcare, our access, quality, our neighborhood, our built environment, social and community context, economic stability, education, access, and quality all impact our quality of life. And these forces and systems include economic policy systems, development agendas, social norms, climate change, and political systems. So it's just important to understand these foundational terms as we move forward in the lecture. We were able to find a very interesting study, next slide, which covers the health-related quality of life, HRQOL, in older kidney transplant recipients. And this study was looking at how health-related quality of life in older kidney transplants is impacted by receiving dialysis or receiving a transplant. So individual studies indicate that kidney transplant is associated with lower mortality and improved quality of life compared with chronic dialysis and treatment. And it's important for us to be data-driven. So that is something we take into consideration when we're recommending whether or not you should pursue a transplant. All right, so those were the definitions I really wanted to cover, but let's go into our very, very foundations. The next slide, we're just going to talk about our kidneys. Most of you attending already know this, so it's probably a review, but your kidneys are two bean-shaped organs the size of a fist. They regulate our blood pressure. They activate healthy vitamin D for healthy bones. They produce red blood cells. That's why when people are having kidney disease and issues, they may often suffer from anemia. They also filter our blood. So when you go to dialysis, you understand that's doing the job of a normal kidney and filtering your blood. And then they also remove waste products from the body, which is essential. and they balance the body's fluids. And on the next slide, just going to cover the basics of kidney disease, CKD. It means that your kidneys aren't working properly and they begin to lose their function. Chronic kidney disease worsens over time, and end-stage renal disease, ESRD, requires dialysis or a transplant. Once you've reached that point, your kidneys are no longer functioning and you do need dialysis to sustain life. And you are also eligible to receive a kidney transplant. You're eligible prior to dialysis, but we will talk about something called preemptive transplant in the next couple slides. So the ability to filter waste products from the blood is impaired. And staggeringly, 37 million Americans have kidney disease, and many more at risk. Many more are at risk. And 1 in 3 Americans are at risk. And most Americans don't even know that they may have high blood pressure, diabetes, and be at risk for developing kidney disease. Some of the symptoms of chronic kidney disease are dry and itchy skin, tiredness or weakness, bubbly or foamy urine, swelling of the hands, feet, and ankles, puffy eyes, trouble sleeping, loss of appetite, muscle cramps, and sometimes needing to urinate more often. Those are just some general signs. When we look at how kidney disease, next slide, impacts us worldwide, it's very important to realize that greater than 10% of the general population worldwide, amounting to over 800 million individuals, are affected by this disease. It is more prevalent in older individuals, women, racial minorities, and in people experiencing diabetes and high blood pressure. It represents an especially large burden in low and middle income countries where they are the least equipped to deal with its consequences. So chronic kidney disease sadly has emerged as one of the leading causes of mortality worldwide, and it is one of a small number of non-communicable diseases that have shown an increase in associated deaths in the past 2 decades. These are really staggering numbers, but it is important. We often look at just the United States, but this disease is obviously impacting many communities and people worldwide. And hopefully, with this education and knowledge, this should prompt major efforts to develop preventative and therapeutic measures that are effective. The aim of these measures should be lowering the incidence of CKD and slowing its progression, and also early identification, which we'll talk about in a little bit. So again, back to some definitions that I think are really important to understand. Next slide. When we spoke about social determinants of health, we also need to understand health inequities. So first and foremost, what does health equity versus equality mean? Health equality means everyone has the same resources and opportunities for good health. Health equity, though, means the right resources and support are given to people based on what they need for good health. So it's actually a better way to handle situations. And I think this image really shows a great example of equity versus equality. And so, like I mentioned, health inequities are directly related to social determinants of health, SDOH, which you'll see as we move forward. So some examples of health inequities that can impact a person's health and well-being are things like environmental exposures. If you live in an area with a lot of pollution, you may be more likely to have health problems like asthma. Or if you live in an area where you may have lack of access to fresh foods, you have food insecurity, maybe you can't afford food, or there just aren't healthy options like food deserts, which we know to exist, where there aren't places that are selling fresh produce. There are corner stores where there's only processed and packaged goods. So those people in those areas might have they may be more susceptible to developing diseases such as diabetes, high blood pressure, and other health problems, because often processed foods are packaged with a lot of sodium and preservatives and sugar. And so Those are some examples of health inequities that are directly related to social determinants of health. Um, we, again, next slide, could not cover the data without acknowledging that there are health inequities in CKD. Social determinants of health inequities are responsible for the high rates of diabetes in Black, African American, Hispanic, Latino, and American Indian, Alaska Native adults. High blood pressure disproportionately affects many Black, African American, and Hispanic, Latino adults. Although Black and African American people make up around 12% of the population in the United States, their rate of kidney failure is 35%. So these are staggering statistics. And thankfully, there are resources and movements in place. The National Kidney Foundation is a wonderful resource for anyone who is interested in getting involved in this. They have created this beautiful and powerful campaign called Kidney Equity for All. I would encourage anyone interested in this topic to go to their website, learn more. They are working to change legislation, policy. I know the American Kidney Fund is taking action to really address these health inequities. So please check this out if this is something you feel resonates with you and you're interested in learning more about. And I'm going to skip to another topic, which is preemptive kidney transplant. Next slide. So I mentioned that when you have end-stage renal disease and you're on dialysis, you're eligible for a transplant. But many people hopefully already know that you can get a transplant preemptively. And that means prior to starting dialysis, you are listed and we are watching you closely, and you hopefully find a living donor and we get you a transplant prior to ever needing dialysis. Why is this important? Well, when compared with dialysis, preemptive transplant patients present a higher quality of life. They don't have exposure to dialysis and health complications. They have documented lower mortality and rejection rates. And they have superior graft and patient survival, which is exactly what I just said. Additionally, there is a lower cost burden. So from a socioeconomic perspective, it is, if society is looking at this as a whole, Medicare is spending over $90,000 per year for a dialysis patient versus the cost of a kidney transplant patient, which is about $35,000. So when we look at it, it makes a lot of sense for many reasons, but most importantly, it's what's best for the patient. This study here, for example, was to analyze whether preemptive transplant extends to recipients who have received a deceased donor kidney with a KDPI score of greater than 85%. And I won't really get into the KDPI score just on this lecture, but basically it's an algorithm and it is used to determine how long kidneys are going to last. And usually kidneys with a KDPI score of greater than 85%, they are less ideal kidneys. They are not going to last the longest compared to a kidney with a lower KDPI score. But what I think is really the takeaway here is this study showed us that preemptive transplant is associated with a lower risk of kidney graft failure, irrespective of the KDPI score. And so the preemptive transplant patients receiving the KDPI score kidneys greater than 85% or higher have comparable outcomes with non-preemptive transplant patients receiving transplants with lower KDPI scores. So we know the preemptive patients are doing better, which is why we always encourage patients to come in for an early referral. We encourage patients to look for living donors prior to ever needing dialysis. And it's really just about being proactive. And this doesn't just fall on the patient. This follows on the care team as well. So we're providing a lot of education to nephrologists, to early refer. We want to get you through the door so you are prepared and know what to expect before you even need dialysis. Let's get you that transplant before you need that. And obviously, we have to cover the barriers to preemptive transplant. As many of you may expect, There are some limiting obstacles. There's just patients who don't know they have kidney disease. They're walking around with high blood pressure or diabetes, and they just don't know. And that can happen. And so that's why doing early detection screenings and going for well visits and checking in and making sure if you have something funky happening, you're talking to your doctor. Late referral from nephrology, that can also happen. Some of our nephrologists may not be as familiar with the transplant process. And so that's our responsibility as care providers in the transplant world to educate and inform and encourage these nephrologists to refer patients early, get them plugged in, and just start having these conversations early. And then one thing that is really important here is that it is difficult for patients to initiate the conversations surrounding living donation. If you don't have a living donor and you need a transplant, you're going on our deceased donor waiting list and you're waiting. But finding a living donor is the best opportunity for you to have a preemptive transplant and just a better outcome because kidneys from living donors last longer. And we'll talk more about how to have that conversation. I provide one-on-one guidance and counseling, but there are so many opportunities that patients may not even realize to find a living donor, to talk about our paired exchange program, our voucher program, and we'll cover those specifics later on. And my last slide before I believe I go to questions is the general prevention and PSA for loved ones. You may be attending this webinar because you already have CKD or ESRD. You may need a transplant, but this is just a big PSA. Anyone in your surrounding area, anyone who is in your family, encourage them to get checked out. It takes such little effort to get screened. Getting your blood pressure checked. You can go to a pharmacy and there's a blood pressure machine. You can have a urinalysis done, and that's just literally checking your urine to make sure that it doesn't have any protein in there. You can have a blood test to get your GFR, which is your glomerular filtration rate, checked out. Judith is going to explain that in the next half of this presentation. But also just getting checked for diabetes. They'll measure something called your A1C, making sure your blood pressure is under control and making sure everything is going well. Get your well visits in, get your colonoscopy. This is beyond CKD. Get your mammogram, get your pap smear, get your skin checked out for skin cancer prevention. My dog feels very strongly you should do that. So all in all, if you have any questions, please let me know. Thank you so much.
Thank you so much, Eliza. We do have one question here. Someone is basically saying that, everyone is aware that living donor is the best option. What strategies can you suggest for finding a living donor?
Yeah, so my first strategy is start practicing having that conversation. Getting the word out that you are looking for a living donor and that you need a transplant is the very first step. We have tools to offer you here at the transplant program, such as the microsite, where you can create a website and spread the word. But the first thing that needs to happen is you need to be accepting that you're going to put it out there. You're going to share with the world that you need a transplant. And then second, educate yourself on living donation. Educate yourself on the process. Educate yourself on the donor protections. Educate yourself on the paired exchange program, the voucher program, and all of the options that exist. Because at this point, all we need is a willing and eligible living donor to come forward. We don't need you to have a donor that matches your blood type. We don't need a lot of things. We just need someone willing and eligible, and our team will take care of the rest. So educate yourself on what living donation entails, what the recovery time is like, what the evaluation is like, so you're more comfortable talking to potential donors or friends or family who may have some concerns about the process. There's something called Donor Shield you should really familiar yourself with. You just need to get the word out and don't give up. It's not a one-time put it out there, you need a transplant and that's it. I also, last strategy, would really recommend identifying a donor champion. So you're the patient, you're going through this disease, you have a lot on your plate. Finding a donor champion, someone who may not be able to donate to you, but is willing to help take off the burden and educate and spread your story is all major. And if anyone wants specific one-on-one mentorship, I will meet with you. It is a very personal thing. Everyone's story is different, and you don't need to have a sensationalized story to have someone want to help you. We have patients, donors who come forward all the time after being touched by someone's story, and we are so grateful for our living donors. They are true heroes in our eyes. So yeah, there's a lot of things that can be done. But first let's start to have the conversation. So I'll put my information, actually it's at the end, if you want to reach out and we can have that conversation. Okay.
Hi, everyone. This is Judith. I see that there is also a typed question. The question is, what treatment is used prior to transplant for someone with high antibodies? This is a very sort of involved situation. And I can see who asked this question, and what I will do is I will reach out to you separately and get back with you to talk with you at length. But the situation basically is this: we can remove these antibodies, but nothing, it's not permanent. So if we have a fixed transplant ready to go with a donor that is compatible, but you do have antibodies against, treating with medication or also filtering your blood, it's something similar to dialysis, we can remove the antibodies. But again, what happens is they come back. So if you're trying to remove antibodies for a specific donor, our recommendation would be to go into to donor exchange and try to find a donor that does not have those antibodies. If you're someone that's on the waiting list, then that's a little bit more involved. So again, I hope that started to address some of the question, but I will contact you some part of today, if that's okay with you, and we can talk about it a little bit later offline. So let's move right along here. So let's talk a little bit about kidney diagnosis. So we basically know what kidney disease is and what the symptoms are, but how do we determine that's what you have? Well, the first test, I think, is very easy. It's a blood test, and it's a level called creatinine level. And what the creatinine is, this is a measure of waste product that is generated by both muscle and protein metabolism. And there are normal ranges. It is just slightly different between male and female. You can see the male is a little higher. And the reason for this is because men generally have a higher muscle mass. So, if you've got someone that's an Arnold Schwarzenegger bodybuilder, then it would be normal for them to have a slightly higher creatinine than that of someone that's sort of thin and frail. In the elderly, we see, of course, reduced muscle mass. And again, that does lead to slightly lower creatinine values. If you have been a living donor or you are living with one kidney for some other reason, then those levels are also slightly higher. We've got one kidney doing the work of two. And so for that, if we see a level in a past donor of a creatinine of 1.8 to 2, then that's perfectly normal for that cohort. So estimated glomerular filtration rate is another level that we use, and you commonly hear this known as eGFR. Your normal levels of eGFR is, if you're someone in your 20s, then we would expect, on average for your eGFR to be around 116. If you're in your 30s, it's 107 or thereabouts. In your 40s, it drops down to 99. In your 50s, down to 93. and your 60s, 85. If you're 70 and older, your GFR on average would be in the 70s range. So this is an estimated value. It is using your creatinine from the blood test, but it's also taking into account your body surface area. So, and your gender. So it does give you just a little bit more detail. When we're looking at GFR for donors, we don't want it to be estimated. We want it to be very specific. And some of your doctors may have ordered 24-hour urine collections for you too. Again, this is just a much more accurate reflection of what it was actually going on. So for those of you that haven't done a 24-hour urine collection, you literally start first thing in the morning one day and go the entire 24-hour urine. You bring your urine to the doctor's office or to Quest in a big brown jug, and then there's things that are calculated that are found in that urine. So one of the things we're looking at is how much protein, how much urine do you make? We're also looking at the creatinine levels in the urine. We take all those things into account, again, with your height and weight, which gives us your BSA, and then that gives us a very accurate GFR. So this, again, is our preferred formula, and there are many out there. You can go on the internet and take a look at them, but this is the one that we use to look at donors. So, okay, these GFRs, well, what does it mean? What does your GFR mean? So if you have normal function, stage 1, your GFR is going to be greater than 90, and this means no damage or some minor damage, and your kidneys are working well. Stage 2 means your GFR is between the 60 to 90 range. That means there is some mild kidney damage. That could just be with age. If you remember, we said people that are 70 plus have got a GFR around 75. Well, people with normal kidney function of 75 fall into this range. There is some mild kidney damage, usually done just wear and tear of daily life, but the kidneys are still working well. Stage 3A is 45 to 59. This is showing mild to moderate kidney damage. Kidneys aren't working quite as well, but probably not having any kind of symptoms, walking around completely unaware. Stage 3B was the GFR of 30 to 44. This is showing moderate to severe kidney damage. The kidneys aren't working as well as they should, but again, probably not having any of the symptoms that Eliza described to you earlier. Stage 4, this is usually where people do start to have some symptoms, and that's with the GFR falling in the range of 15 to 29. This is where the kidney damage is severe, and the kidneys really are getting close to not functioning at all. And this is the stage that we really want to start to see people for transplant. I don't want to see people when they're at stage 5 and they're already on dialysis. They've already lost that window of the chance of getting a transplant before they start dialysis. So if someone calls us and says, we've got a GFR of 28, I will spend time talking to them, explain it's too early for you to actually start to accrue waiting time, but let's get you ready, come for the education, and find out about what your options are going to be down the road. That way your back's not against a wall when your kidneys do deteriorate to the point that something further needs to be done. And that point generally is the stage 5, where your GFR is 15 or below. Some people will say that they're having symptoms with a GFR around 20. Other people say that they feel absolutely fine. I think what happens in a lot of cases is that the kidney disease is slowly progressing. And so you sort of get used to not having the amount of red blood cells that the normal person has. You get used to having the buildup of the poisons and a higher creatinine so that you're not feeling the symptoms the same way as if it was an acute setting. People come in again, they've got creatinines of the mid 3s, they feel absolutely fine, they're working full time, they work out. if you gave me a creatinine of 3.5, the chances are I wouldn't get out of bed. So it is, you know, there is a tolerance involved in this too. So kidney disease diagnosis sort of continued here. One of the most frequent tests, and many of you have probably had this, is a renal sonogram. And why we do a renal sonogram, knowing that you have kidney failure is one thing. Knowing what caused the kidneys to fail is something completely different. If we know what the cause of your kidney failure is, we can hopefully slow it down or even in some cases reverse it. So this is still a hope when we're evaluating, you know, your diagnosis. So the sonogram itself looks at kidney size, the shape, where it's located, where your kidneys are located, if they're in a normal location, what the related structures, that's the ureter. The ureter is the tube that goes from the kidney and takes the urine down to the bladder, and then the bladder itself. Sonograms can also detect sign of injury or damage that would cysts, tumors, abscesses, or any obstructions. If the ureter is kinked or it is blocked for one reason or another, then that will cause a backup of urine back up into the kidneys and in turn would lead to or could lead to kidney failure. It can also show infections or fluid collections around the kidney. So again, knowing what caused the kidneys to fail is extremely helpful, and having that diagnosis can, to some degree, you know, lengthen the time it takes to progress to kidney failure. One of the other things that we use is a renal biopsy. And we used to do a lot more, I think, kidney biopsies than we see nowadays. I'm not quite sure of the reason for that. But if there is no clear diagnosis from your renal sonogram or from your medical history, then the doctors will sometimes do a kidney biopsy. So again, we know exactly what's caused your kidney disease. Sometimes if there is a treatment in play also, it can measure, you know, how effective has that treatment been? Are we slowing the progression? And you know, the biopsy can be used for that. It is something that we use post-transplant. If someone has an issue and we see an increase in creatinine, the first thing we worry about is rejection, and a kidney biopsy would be able to diagnose that very easily and quickly. And it's not a big procedure. It's not an operating room procedure. You can be done in the doctor's office. It's usually done under sonogram. You get local anesthetic, and the biopsy is obtained. So what are the causes of kidney disease? Well, you know, the major contributors to kidney disease are diabetes and hypertension. And, you know, this isn't an overnight phenomena. This is usually something that people have had for a period of time. And so, you know, are in the system. But it's very difficult unless you've got a very, very good control of the diabetes and blood pressure, that for it not to affect your kidney function to some degree. So you see on the little graph, the pie chart on the right side, if you add the diabetes and the high blood pressure together, then you're talking 73% of patients that have got end-stage renal disease are covered with under those two umbrella illnesses. 20% are unknown cause. If you come and you see the physicians and you have an acute onset, you start to, you get the symptoms that take you to the emergency room and you're diagnosed with renal failure. If we do a biopsy at that point, the chances are it's really not going to show very much because the damage to the nephrons within the kidney is just too far gone to be able to give us a good diagnosis. There's inherited diseases where polycystic kidney disease is probably the most common of the inherited diseases. And then we also have Alport's is something else that we see. Congenital abnormalities, this is where there are some form of anatomic malformations. This is very common when we're talking about pediatric patients with kidney disease. You know, that may be, you know, from birth, and these things have to be surgically corrected before the transplant could even take place. There's the autoimmune diseases, lupus, again, probably, the leading culprit. Kidney stones, if you have kidney stones in both of your kidneys, that can be a real cause for concern, and we like to diagnose what is creating the stones so that we can then, again, treat the underlying cause. Renal tumors, it's not so uncommon that if you get a renal cancer or kidney cancer on one side, you do end up developing the same tumor in the other kidney. So that's another reason that we do see people coming for transplants. Urinary obstructions in the older generation, the older men can have enlarged prostate. I think if there's anyone on here, they can say, very often at night, they're going to the bathroom 2, 3, 4 times a night. And that's just because they're not emptying their bladder each time they go because of the enlarged prostate. And again, that's something that needs to be surgically corrected. But unfortunately, correcting it will not bring the kidneys and improve the function. Also, kidney infections. This is not something to take lightly. If you have kidney infections and they're recurrent, then you need a full workup to find out what's causing them and get that problem sorted. So let's talk about a little bit about patient survival, and this is comparing people that are on dialysis versus transplant. So what this specific study, looking at 3,500 patients, the annual death rates in this group of people, for the patients that were on dialysis, the annual death rate was 16.5%. For those people that were on the wait list, it was 2.4%. And for those patients that had undergone kidney transplant, it was 1.2%. So when you put this all together, what that tells us is the relative risk of death is 5 times higher if you're on dialysis than if you're on a waiting list or received a transplant. So I'm going to let that sink in for a second. 5 times higher. It speaks its own story. So back to the preemptive kidney transplant. This is certainly in an ideal world. Everyone that needs, that reaches end-stage kidney disease, the treatment certainly would be a kidney transplant. And in all honesty, really the only way to get a kidney transplant before you go to dialysis is through living donation. So this is not a new phenomenon. We've been doing living donor transplants. The first transplant we ever did, the kidney transplant we ever did, was back in 1953, and it was a living donor transplant. The last 15 years, despite having this knowledge, the rate has failed to increase. I think the nephrologists are more aware of this now. Certainly organizations like the National Kidney Foundation, they've really tried to promote living donation as the treatment of choice for patients with kidney failure and end-stage disease. But 15 years, there's been no increase. So only, that's, it's a sad number. What does it do? Lack of early referrals. Again, you come and you're already having symptoms and your doctor's already saying we need to do access for you to perform dialysis. Then the opportunity to be able to do a preemptive transplant is really passed at that point. It could be that the donor's got a lengthy evaluation, or the recipient for that matter. It could be that the donor comes, they're slightly overweight, they need to lose some weight, and it can take a while, for them to actually clear some of the, requirements that we have. And of course, ill health or adequate insurance are things that I think are really the major barriers in this day and age. But again, it's a sad number. So patient survival following transplant. So this is at 5 years. So you get your transplant in 2020, and now we're looking at 2025. For living donor transplants, patients between the ages of 18 to 35 that receive a kidney transplant, close to 98% of those patients are alive at 5 years post-transplant. You look at patients between the age or 65 and older, that number is close to 84%. Now let's move over to the deceased donor transplants. So you're looking at recipients between the ages of 35, very high patient survival rates at 5 years. You're talking 95, close to 96%. So not a big difference between the living and deceased in patient survival. Not for the younger generation. When you look at the older cohort of patients, that's 65 or older, that number does drop to 74%. So there you're looking at almost a 10% drop in the same age group. But again, just reinforces the message that we keep getting across. 5-year survival rates higher amongst living donor kidney transplant recipients than amongst the deceased donor kidney transplant recipients within the same age group. Waitlist statistics. So again, lots of numbers. This is data, throwing data at you. So while transplant success rates are high, and those absolutely, it's not arguable at this point, certainly into the high 90% range. 34.6% of patients that remain, 34.6% of waitlisted patients do remain on a list for more than 3 years. So you're talking a third. Now this, I just want to clarify, is national. This is not New York. New York and California are two areas that what the waiting time is much longer than that. And if I were to estimate, I would say that that number in the New York area is more like 60 to 70% rather than the 35% nationally. 25% of patients had undergone a deceased donor transplant. 14% had undergone a living donor transplant. 6.4 patients had died, and 20%, or 1/5, have been removed due to either patient request or ill health. So again, this is the national statistics and not the ones in New York. And, it sounds very repetitive and almost boring, but it just further underscores the importance of getting to be evaluated for a kidney transplant early on. If you can have 3 years of wait time under your belt in some circumstances before you even start dialysis, why would you not do that? So this is why we do try to get the messages out earlier and earlier. So some of you may be, if you're on a waiting list, then the United Network for Organ Sharing should be, familiar to you. For those that are not, it's a private nonprofit organization, and they manage the nation's organ transplant system, and they are contracted with the federal government to do so. They have been under a lot of fire in the last couple of years because they didn't feel that, we're really in a crisis as far as organ shortage, and anyone of you that was waiting for a kidney transplant would agree with that. And they just feel that enough has not been done to be able to address this problem. Well, anyway, they partner with the network of transplant hospitals, just like here at New York Presbyterian, Weill Cornell, and also the organ procurement organizations. So that is the group of people that actually go out and procure organs from the deceased donor transplant. But also take care of all the numbers of all transplants, not just the deceased, but the living donors as well. So some numbers from UNOS. In 2023, there were over 46,000 organ transplants that occurred. And this is an increase of 8.9% from the prior year, 2022. Again, last year, 2023, there were over 27,000 kidney transplants performed, and this is a new record for the United States. So deceased donation does continue to improve, and it has for the last 13 years or so. So it might not be by much, but it is improving. As of last week, January 25th, when I was putting some of these slides together, there were 103,327 patients on the donor waiting list. So that's all organs. Over 93,000 of those are waiting for a kidney. So that's 87% of the wait list is people waiting for a kidney. Mind-blowing. A little bit of news for older candidates. In 2020, organ rejection does not necessarily mean graft loss. What that means is the body's antibodies are attacking let's assume it's kidney in this instance, are attacking the kidney, and that is usually reflected in an increase in the creatinine level, and something we pick up. We diagnose by doing a renal biopsy, and hopefully the medication, by increasing or giving you a special something else, that will sort of get the rejection under control. So it doesn't mean graft loss or kidney loss. It means the body was actually, attacking the organ. So in the age group of 18 to 34%, we see rejection rates of about 9.1%. So that's 9 out of every 100 people are going to have at least one episode of kidney rejection. In the older recipients, that number drops down to 6% or 5.9%. And the reason for that is, again, you see this on the news all the time when we're talking vaccines and, who is the most at risk for disease. As you get older, your immune system gets weaker. And with a weakened immune system, one of the only benefits is the fact that you're less likely to reject your kidney than you would if you were younger. I just thought that was an interesting statistic, that it's about 1 in 10 actually have rejection. So what are the conclusions? We've thrown slides at you, we've thrown information at you, but I think there's some things that we need to really just, again, focus on what's important here. So any patient that has a GFR between 20 to 30 certainly needs to be closely monitored by their own nephrologist, so that we can talk and open the discussions of transplant or what type of dialysis you need in a timely manner, and not have everything work as an emergency. And hopefully you will be referred for an evaluation for kidney transplant. The treatment option for end-stage renal disease, transplant still offers the best prospects, certainly offering a longer and better quality of life. If you finding a living donor, you can avoid the long wait for a deceased donor and/or dialysis. And we know it's tedious, we know it's lengthy, it's not, you can't go to Walmart and pick a kidney out. We know that, but there are ways to do this. And, my message would be, do not become frustrated. There are ways. We are going to do another webinar and address how we can help find a donor. Microsite is something that Eliza works very closely with, allocating a donor champion, a spokesperson for you if you're not comfortable addressing this yourself. And certainly social media has played a huge role in the last couple of decades, helping people find a donor. So, but while searching for a living donor, I would certainly contemplate all the deceased donor options. What does it mean? Can I take a hepatitis C donor? What does that mean to me long term? And also, consider multi-listing. And again, these are things that we will talk about in upcoming webinars. So please join us for that. And hopefully, we can get some new information out to you. So any patient that's nearing end stage, decide on the type of dialysis, those options. The government is really pushing dialysis to be done in the home and get people out of the dialysis centers. I think that this is certainly beneficial if at all possible, but in certain circumstances it isn't. And don't delay the onset of dialysis. If your doctor is telling you that you need dialysis, then please do so. I've been in transplant close to 30 years, and I cannot tell you how many times people have fought the start of dialysis, and then as soon as they've gone on, they say to me, I should have done that 6 months ago. It does do irreparable damage by delaying, so please do not do that. So take-home message. Kidney transplants have got high success rates and certainly remain the preferred treatment for end-stage renal disease. Getting a deceased donor transplant can take several years, so you need to list as soon as that GFR reaches 20, which is when you qualify. Could have 3 years, potentially more, before you actually need dialysis. Doesn't matter, you're getting waiting time. Finding a living donor, tedious, lengthy process, as already mentioned, but it does certainly lead to the most successful outcomes when at all possible. And spread the word regarding your donor. You can't afford to be shy about this. I've not had to do this. I can't imagine what it's like, but talking to people that fought it for quite a while and then said, how, I'm going to get the word out. They certainly wish they'd spoken up sooner. So the earlier you get evaluated, bottom line is the sooner you receive a transplant. So little bit just about the program. This year's been 2023 was a big year for us. We did 286 kidney transplants, and 105 of those were living donor, or 38%. We are the #1 living donor center in New York, and we're 10th in the nation when we're talking volume. We did our 6,000th transplant. Our program has been open since 1963. So that gives it's our 60-year anniversary. And last year was actually our highest volume in those 60 years. So we're headed in the right direction. So this is just a little bit of a graphic. Here are the old pictures. Old people, old photographs of dialysis. I think the one in the middle on the left, that was the first child that was born to someone that had undergone transplant. I mean, there's a whole very interesting history. This is our website. If you've not been, I think it's worth a visit, weillcornelltransplant.org. It is a massive information. It's living donor, it's deceased donor, it's just everything that you could want to know. There's pancreas transplant, pediatrics, you name it, it's on there. And a lot of testimonials from patients that have been there. They've going through what you're going through now, and they talk about their experience and what it means when they finally get a transplant. So well worth a visit. These are some additional resources, and you will be getting a copy of the slides. Everyone that registered today, you will get a copy of the slides, and so this will be in a little package once it's sent out to you. And questions, I do see. Oh, that's the same one.
I think we were able to answer all the questions, and the person who I asked them for their email, I found your email. It's not a problem. I have that already.
Great.
And Judith, I already sent it to you so that you can contact.
Writing it down. Okay, perfect.
No problem.
All right. So if we're done with questions, I hope this has been informative and that you've learned something today. And this is the agenda up and coming. So February 27th and the 28th. The topic is navigating the transplant evaluation process and what you need to know. In March, we're doing transplant success stories. So there's patients that have gone through this and sharing their experiences. In April, we're doing living donor kidney transplant, again, stories of generosity and renewal. May, exploring paired kidney exchange. June, managing medications. July, challenges and triumphs, navigating life following transplant. And August, nutritional considerations. September, mental health and well-being. October, we're doing transplantation in pediatrics, unique challenges and successes. And I can't see, my screen is actually cut off there for what's in November. I'll have to bring that up next time.
November is advancements in kidney transplantation and a comprehensive overview.
Thank you, Melissa.
No
Thank you so
problem.
much. So that's what we've got coming up this year, and I certainly hope you'll be able to join us. So that's all for now. No questions. Hopefully see you next month.
Thank you all so much for joining us today. Judith, thank you for such a wonderful and insightful presentation. And we really appreciate everyone spending their morning with us. And as Judith said, we look forward to seeing you all next month. Have a great day, everyone.
Bye, everyone. Bye-bye.